Allow me to invite one of my mentors, a support system, and my lecturer in psychology that I met in class from January to December in the year 2024, and I believe I'll also be in her class starting this May. And that's none other than Dr. Carol J. Watson from San Diego, California. She's a practicing clinical psychologist who is licensed in Kenya and California, USA. She's an assistant professor of psychology at United States International University, Africa. She's an American, and just a week ago I learned she's also Kenyan. I don't know how that's possible. So it's my honor to invite you, Prof, to come and address us today.
Thank you. So I have made notes, and I'm hoping I will refer to them occasionally. First thing I want to say before I get anywhere into speaking is that I have talked to Teresa about opening for questions. Some of the things I want to talk about obviously pertain to our profession, and I'd also like to hear your questions. If you have any that you'd like to ask, you can interrupt me with your hand, or you can wait till I get through a few points, whatever you'd like to do. So I am a clinical psychologist. I finished my doctorate degree, which is Doctor of Psychology, Clinical Psychology, PSYD, in the year 2000. It's been a day or two, in San Diego, California, where the original USIU was located. And this campus here was a sister campus for many years. And now, as most of you probably know, it's an independent campus here at this point. And so the only USIU left on the planet. So the USIU in San Diego and the ones in California merged with California School of Professional Psychology and changed the names to Alliant International University. So it's really the same core program, but under a different kind of umbrella. Okay, the reason I'm just mentioning that is because I just want to say that there's some confusion about the difference between PhD and PSYD. So whenever I get a chance to talk to people who are in this field and aspiring to maybe go further in this field, to know that this is a practice model, meaning there's more emphasis on learning the skills of clinical psychotherapy, assessment, case conceptualization, diagnosis, treatment planning and treatment, psychotherapy skills, psychometric skills, etc., etc. Now, some of that is also in a PhD in clinical psychology, but the big difference is about the emphasis on research, which is in the PsyD, but there's much more emphasis on practice model, including some differences in how the dissertation can be done. And I'm also mentioning that because when I came to Kenya in 2010, I've been in and out of Kenya since 1990. But when I was invited to come back in 2010 by the former Vice Chancellor, Frida Brown, when I first got here, I was meeting her for like a couple days after landing, and she said, Carol, we need to expand psychology at USIU. We've had the BA psychology and the MA counseling, and that's all we've had for years at that time. So we did, and I was part of that team that developed the MA clinical and then the PSY, the PsyD clinical, and went through the whole accreditation thing with the US and Kenya Commission for University Education. So it was quite a learning process. I don't think anything could prepare me at the time for the amount of work that was, but I'm not a quitter. I just give me the bone. Somebody used to tell me, Carol, you're like a dog with a bone, you just don't know when to put it down. And you know what, that's still true. This profession has changed my life. My former life was in the corporate world in the United States. Just to say that I got to a point after about 15 years in the corporate world, which I learned a lot about management, team building. I was a national trainer at the time of the major corporation, and I just got to a point where I said, this is just, it's not enough. I'm not motivated to do this anymore. So I did make a big change, and I went back to school in my late 30s and finished my bachelor's, partly over here at Mayfair, the old Mayfair. And then I just stayed in and finished my master's in clinical psychology in San Diego, but did some of it over here when I could find a class to transfer, a few classes to transfer over here, which I did. And then sitting in my master's graduation, I saw a friend of mine sitting like 2-3 rows ahead of me who was graduating that day with her doctorate. And she and I had studied, we had some classes together. I don't know why we were mixed MA and doctorate, but whatever. We had a few classes together. And I also spent time with her as a friend, you know, hanging out, studying together, whatever. And I'm sitting there about to, you know, graduate with my master's, and I'm looking at her and I'm thinking, she's not any smarter than me. You know, maybe I could do this doctorate. Because I'd never thought about doing a doctorate before. It's a doctorate, those are the super smart people, you know. I didn't want to set myself up for failure. Who does that, you know? So I just said, wait a minute, I think I could do this. So I immediately applied and was accepted. And my first choice for psychology was to go into industrial organizational psychology. I'm going to get off of my person stuff here in just a second. But I just want to tell you that industrial organizational psychology is also a huge field, and we need to bring it here. And I am advocating for that where I teach right now at USIU. Because industrial organizational psychology is a specialization where we combine what we know about working with people, but it's applied in the workplace. Like with team building, yes, or management supervision, management skills. Also, IO psychologists do surveys and assessments on employee satisfaction, things that really are important to employee motivation. Anyway, I'm also working on a couple other things with the university, and I'm probably just going to be around until they either tell me to go or they incorporate what I'm recommending. Could be both, I don't know. So let me just say that first of all, I want to talk about ethics, and I want to talk about stigma, and I want to talk about suicide, and then a couple other little things. And I hope to leave you with a few gems. You know, if I could walk out of here in a little while and feel like there's something I shared with you that was important to you, that's what I'm hoping I will do, and I will see if that's true. So I want to advocate for this profession because there is nothing to me more important than assisting our fellow human beings, especially when we learn how to do this in a professional and ethical way. It's so rewarding to be sitting with someone and the light bulb goes on and you can see the shift or hear the shift and how they're seeing themselves, what their thinking is like. This does happen, believe it or not. And it's really so rewarding to work with people and be able to share what works and what people are doing to themselves and their thinking, which is where the origin of many disturbances occur, right from what we think about. But first of all, let me say that it's very important that anything we do in this field, the number one motto is do no harm. Do no harm. So and anybody could talk about ethics till, you know, the cows come home tonight. But we need to really honor the profession and honor yourselves within the profession to do no harm. What that means is if you don't know the answer or you don't know what to do with this patient's question or this patient's presentation, if you don't know, then what's the answer? What do you do? What is it? Refer. And it's okay to say to the patient, you know what you're talking about is something that's more specialized than I can help you with. And I want to be respectful and find a therapist that can help you with this particular situation you're experiencing. So we don't have to make them feel wrong or something's wrong with them. It's just you honoring the ethics. You could even say that. You know, one of the ethical standards that we need to honor and that I need to uphold in our profession is that if I don't, or someone else in our profession doesn't know how to treat an eating disorder, or how to treat domestic violence offenders, the list could go on, then we have a responsibility to refer that person. There's a lot of referral opportunities in Kenya. It's growing like crazy. When I was here several years ago, well, going back even to the 90s or even the early, the 2000s, there was not a whole lot going on in mental health, as you probably know. But now, look at this room. And by the way, I just want to tell you that, in my view, what you've gained so far is a good beginning. It's a beginning. In fact, I was thinking about playing this song from Chicago. Do you guys know about Chicago, the band in the States from years ago? They have a song called It's Only the Beginning. And I think that's a theme I would share with you and suggest. Because what you've learned so far is likely only the beginning. There's so much more to learn. And this is another reason why this field is so exciting, because we never learn it all. There isn't anybody that knows it all. Isn't that sad? But it's true. We can't, in any profession, if you think about it, any scientist that's working on a specialization, knows that specialization. A clinical psychologist who specializes, let's just say like the example I gave of eating disorders, or specializes in psychosis, or specializes in treating phobias, or whatever it might be, that's an area of specialization that not everybody can do. If you have somebody that comes to you and they have this significant phobia of, snakes, it comes to mind, and you don't know what to do with that, please don't start bringing snakes into the therapy room as if that is going to habituate them to being okay with snakes, because what you're going to do is re-traumatize. And that's what I mean by do no harm, is doing something that you think might be helpful. My example is not a great one, but I do know some therapists who have used what we call exposure therapy, and it's so easy to re-traumatize people. You may not even know that that's happening unless you find out from the patient, or you don't see them again, because they're like, oh, is this what therapy is? And that's another reason why it's so important to represent the profession. To do no harm. To learn what you need to know so that you can be as effective as you can. And that brings me to supervision and consultation. As someone said, refer if you don't know what to do. Well, one way we learn is through supervision and consultation. And I don't mean with your peers, although that's okay. But more importantly is to go to someone who is actually a mentor, who has more experience than you. And we do have several people in the country who have a lot of experience. But even these individuals sitting at this table who were my students for last year, and I'll have them again in summer. So I wear a different hat when I'm with them in the classroom, you can imagine. But we're all in the process of learning, whether it's in a doctorate degree, whether it's mental health, support, first aid. It doesn't matter what our role is right now, it's where you want to go with it. Because this learning is not something like algebra where you push yourself to figure it out and then you can close the book, okay, I know algebra. This is not that field. Because we're working with human beings. And every human being we work with has some uniqueness about them, just like we each do. And so, it's really learning how to, Teresa, you were saying something about not having the skills because we didn't do our own therapy, and then we have someone in front of us that it triggers us because we haven't finished working on our own stuff. Well, in a way, if something comes up like that for you, pay attention to it and get support. If you're advocating for mental health, then advocate for yourself as well, so that you become more effective in the therapy room. The more effective you are, you know, the better you're going to enjoy what you're doing, and the patients will be grateful. And you'll have a building, you know, good practice. You know, back in the day, and I don't know if this is so true right now, but I used to hear that students would say, you know, I can't really get into psychology because my parents don't think it'll make any money. You know, they want me to go into this or that because there's money. But that's not so true anymore. If you get the credentials and the credentials to, you know, get licensed, can you now that we can get licensed here and do your training or even continue your education, which I would highly recommend, because you really do learn in the master's and particularly the doctorate. You know, it's a journey. But I always just say to myself, the time's going to go by anyway, you know, God willing. So why don't I invest in myself? And that's kind of how I got through it, because it is a journey, but it was enjoyable. And just as some of you have said today, your journey here was enjoyable, even though it was work. It's very much worth it. So I wanted to just touch on ethics. I think I've had a bit, but it's very important to learn ethics in psychology. If you even access, choose to access American Psychological Association's ethical standards of practice in psychology, you can access that online. You can go to the American Psychological Association's website. I'm not here to advertise, I'm just sharing information. But you can access that at the ethics, the list of law and ethics. There's also some really good books out there by APA. If you ever do decide to come to USIU, you have that book at the library, many copies. And that is the standard we use in teaching ethics. So I just want to encourage you, even now, that when you start working with people, that you don't think that you have to know everything. You don't. You're not going to. But the more you practice and consult with a mentor, supervisor, someone who you know now or someone you may gain to know at some point, that you consult and you ask for help. I have people that I used to teach who have now graduated that call me. Dr. Watson, do you have 15 minutes? I have a quick question on a case I'm working on. I'm like, yep, I'm good, call me. Or, how's it 2 o'clock? We could talk then. And this happens occasionally. And it's very interesting because, see, people that are graduating have the academic as well as the clinical experience training that is done. Can narrow into what the question is that they need to know, the guidance, or just the reassurance, yes, I'm on track, or, whoa, where are you? Come back over here. Come back to my room. Okay, so the next thing I wanted to talk about is stigma. You know, there's a stigma in worldwide. It isn't unique anywhere. There's a stigma on mental health in terms of, oh, those people are the crazy ones, or there's just a lack of understanding about what goes on. Not everybody that is in treatment, by the way, has an actual mental disorder. A mental disorder through the DSM-5-TR is, you know, what we use globally to diagnose a disorder. But there can be people that have some of the symptoms that are still having some level of impairment, but they may not meet the full criteria for diagnosis, let's say for major depressive disorder or post-traumatic stress disorder or, you know, bipolar or whatever there are. There's so many. And that's one of the things you could learn actually about all the diagnosis in hardly master's, but definitely the doctorate. It's inappropriate to try to learn that online, by the way, just by the way, because this is not a field where you can self-teach. You can learn some things online. There's great podcasts, workshops, but that is not giving you the whole enchilada, so to speak. It's not giving you the whole realm of what you need to know to really hear a patient and know what the questions are that you need to ask for a clinical interview. to begin to understand what's going on with a person and to listen for symptoms and to be able to kind of have a decision tree in your mind about, oh, it looks like it might be anxiety. Let me ask a couple questions about social anxiety, acute stress disorder, general anxiety, PTSD, etc., etc. Or it sounds like it might be depression because he's saying XYZ, 4 or 5 symptoms that are being mentioned. So, let me ask some questions about it. So learning how to do this without having to look it up is where you eventually get. And even I still look stuff up because I want to be accurate. So if I'm not sure 100% of my diagnosis, even based on the years I've been doing this, you see, it doesn't matter how long, it's the fact that, oh wait, let me double check this. And I actually just did that the other day. On a differential diagnosis I was trying to clarify. So anyway, back to stigma. So how do we reduce the stigma in kidney? What have you thought of? Do you have an idea? What? Awareness. Yep, awareness, and I think awareness needs to actually be structured. We can't just depend on a news article or somebody on TV saying something that could actually be biased in some way or another, right? Just not totally correct information because that's not their training. But we need to do that. We need to be out there, first of all, doing no harm, and secondly, knowing what we're doing. That's how we build the profession. The more of us that are out there where we are assisting and supporting patients, whether it's an individual, couples, family, I do a lot of parenting skills training, workshops, whatever we might be doing. I'm even involved right now in writing a support program for women who have experienced or are experiencing domestic violence. And there's a small group of us working on launching that fairly soon in different parts of Nairobi. And we need more programs like that where people can get information on what they can do for self-care. So, reducing stigma means informing people. So if we're not well informed, how can we inform others? So first of all. The second, as you see people in practice, the more professional you are and the more accurate you are with what you're recommending in treatment or recommending in whatever the process of the treatment may be, the more professional and using evidence-based practices, the higher the standard that you're presenting to that patient. Because they may not have had that experience before. And we do know there are people practicing in Kenya who really are using advice as a way of what they're calling, counseling or therapy. Advice is not therapy. People can go to their sister, brother, mother, grandmother, best friend for advice. They can look at the mirror and do advice. So if you think that you are going to try, not you, any of us that are in this field, not just in this room, think that we can sit in front of somebody and try to problem solve with advice, you may not see that patient again. Because don't you know, they're paying for a session and they can get advice anywhere. Well, have you thought of doing this? Or did you think about that? Or what about this? Or what about that? Well, what happens when you run out of your ideas? Well, then what? Then you're sitting there in silence like, oh my God, I don't know the answer to this problem. You're not supposed to know the answer to their problem. What you need to be listening for and asking about are the symptoms that issue is causing them. We treat symptoms, Even if a woman, in my example, is in a domestic violence relationship, actively being abused, I'm not going to sit there and give her advice. I'm going to weigh what she's thinking about. How is she taking care of herself? What does she see as her options? What is holding her or keeping her there? There's reasons people stay in relationships, as you all know. Nobody needs to tell you that. Whether they're positive or not so positive, there are people who like to stay in relationships. Okay, are we in the profession going to criticize this person because they're making a choice? No. We're going to work on symptoms and support their choice and honor and respect their choice, because that's how we get the closeness and the relationship and the conditional positive regard that is in our profession, by the way. That is, in addition to do no harm, it's the flip side is that we offer unconditional positive regard. So if someone in front of us is talking about something that we are just so turned off to, give an example, like let's just say the LGBT population, there are people who will not work with that population. I also know that somebody in the field who used to have associated with this person for many years, who used to say they would never work in their practice with anybody that's getting divorced, or even divorced, because they didn't believe in divorce. Do you see how that personal belief spread over to how the person will decide who they're going to work with? That is not unconditional positive regard. On the other hand, if we have a limitation with people we want to work with, it's really okay to choose no. Refer that person, or if someone's referring to you, I have this patient who, blah, blah, whatever their identity is, even a different culture, maybe not a Kenyan, and then you don't, I don't want to work with that person. Well, then don't. Because you will do harm, whether you, well, there's a high likelihood you may do harm because you're not able to hear the person objectively, right? You already have some, now, unless you want to get help with that, what do we call it, self-defeating belief that you've adopted somewhere about not liking certain groups or certain people or whatever, you get help with that in your own therapy, examining why that is and if you want to keep that belief or not. And then you may find yourself a little bit more objective. But it's okay to decline. I mean, I've worked with people who, therapists, who say I could never work with anybody who's committed a crime or caused harm to people. Okay, well, good luck with that. There's a lot of people that have caused harm that do eventually show up in therapy, which is great. Now, we don't know what to do with that because we're angry because of what they said they did. If we're angry, we're not going to be serving. We're going to be punishing in some way, or we're doing advice, or we're condemning them for what they did. Okay, I think you get the point. So, I want to talk about how to get rid of stigma. Okay, I'll just repeat this. How we reduce stigma is by increasing our skills, individually and collectively, and represent the profession first. The integrity of the profession of psychology. That's a responsibility. When I got licensed in California, there's a whole national exam in the United States. It's just unbelievable. 4 hours long. It's a national exam in the United States, but it's the same one in Canada. It's a huge exam. You study at least 4 months for it, seriously. And anyway, lost my train of thought there. So it's a huge exam, and you get into the field finally, and then you think you're supposed to know everything, but you really don't know everything because we haven't worked with this person yet, or this diagnosis yet, or how to do treatment with this, or So it's ongoing learning. That I think is what I was talking about in upholding the profession. So don't think that even my students at the highest degree in the world, seeking a doctorate in psychology, when they graduate, will be a new beginning, isn't it? So, do we ever really get cooked in this field? Do we ever say, okay, we're done? No, we don't. I mean, I'm working on over 25 years in the field just since I graduated. And I also had experience before that. No, because who's going to show up tomorrow in my practice is a new person. I haven't met them before. I don't know what they're going to bring. I don't know what they're going to say. But I'm there. I'm meeting with them. I want to hear. I want to know. I want to be helpful. And I want to be professional. And my first loyalty is to uphold the standards of the profession. That's competency, ethics, do no harm, unconditional positive regard, Maybe you've heard some of this already. So I think that's really how we can reduce stigma, because the word will spread. Your name will spread. People will refer people to you because your name will become known. When you hold up the ethics and you learn what you need to learn. And, you know, there are things going on in the country that need to change, like what's going on with suicide, another topic I just want to talk about real quick. Well, it deserves a long conversation. When I found out years ago that suicide was considered illegal in Kenya, I was pretty much blown away by that. I'm like, what? That means people aren't receiving treatment. So if they attempt suicide, I mean, you know this, right? I'm not telling you anything you don't know. They're punished by incarceration. Now, I understand that a change is happening, but in a vote that now is making suicide attempt not to be illegal, but I understand that also has not been actually signed into law yet. Is that right? Yeah. And I'm like, well, what's holding that up? How many more years is that going to happen? You know? So, as far as I know, it hasn't been signed into law yet, but I was asking a colleague of mine who's been in Kenya, you know, a long time, said, well, when it actually becomes fully operational in the country, where it's no longer punished by incarceration, does that mean the people that are incarcerated for attempting suicide will be released? Because wouldn't they? Shouldn't they? They're improperly punished to begin with. That was a law. Now if it's changing, and I'm just wondering how that's going to work. But here's an opportunity for us to advocate that these people be released through communication among us or other groups that you know. But in the profession, within the profession, there's a lot of associations in Kenya, through the associations, to make sure that this gets changed, but also, even more importantly, if that's possible, is that we really don't have a protocol on suicide intervention in Kenya. Do you know that? There's no standard assessment protocol that is used in the country. And I'm basing this on some research that a former doctorate student did, where I was partially supervising him. And he did his research with a sample. It wasn't a huge sample, in all fairness. But the sample that he had of some psychiatrists and psychiatric nurses, this goes back some years, by the way, not too far back. But he interviewed them with a standard interview, and what he was wanting to find out is what was your training like during medical school on suicide prevention intervention. Second question, what assessment tools do you use? Is there a standard tool that you use in your profession, your daily work, if someone is reporting suicide ideation, intention, planning, etc.? And the third question was, if you have a patient who's telling you they're suicidal, what do you do? So the answer to the first question was, this is the majority, I'm not going to say it's all of them, and I know it was a fairly small sample size of about 80 total psychiatric nurses and psychiatrists in different parts of different hospitals. So the first question was, the training on suicide, it was mixed in with some other class that couldn't really remember what. So marginal, I would say. And then, are you using any standard assessment tool now? Do we have those? The question to the research student was, do we have the standard assessment tools for suicide risk assessment? And they didn't either know about it or weren't advised to do it or whatever. In the profession, it isn't there. And I think that's true among us also psychologists. We need to really work on that in reducing suicide. If you can't assess and know risk, what are you doing? You have to know the level of risk. Is it ideation because they just failed an exam, or a family fight, or a separation with a spouse? You know, what was the trigger, and what can happen for this person to resolve that? But many times people think, I'm done, I'm tired of this, the pain's too much. That's what we hear. The pain is too much, and suicide looks very real, like a real, rational option to end the pain, whatever the pain is. That's very real. That's what we hear. And if we're sitting there listening to that, and we don't do a risk assessment to really use professional, valid, reliable tools, one is called the Columbia scale. There's others. I'm actually using the Columbia scale and teaching it in my classes, even if I'm not teaching on the subject of suicide, because I want to just slip stuff in that we need to know. But anyway, how we can reduce suicide is training among all of us and the medical community, because many people will go to the medical community, right, before they'll come to us, because they might be reporting some somatic symptoms, and the family member says, oh, you're not getting out of bed, you're not eating, da da da, so they may go to a medical, and if medical isn't trained to do assessment, suicide assessment, they may never come to our profession. But anyway, so we need to do training with all of us, anyone that works with human beings, to do training on risk assessment, and also standard protocols for if there's high risk or moderate risk, what do? There should be a standard, not should be, there needs to be a standard protocol that if you're a psychologist, counselor, first aid, mental health representative, or you're a psychiatric nurse or any MD, you need to know this so we can intervene on suicide in Kenya. And it is not really difficult to learn. It's more about your own sense of what to ask, how to ask it, in a way that is not confrontational or condemning or advising or any of that. It's like asking questions just like you might make. So, who is with you at home? That tone. So how long have you been thinking about taking your life? Are you having thoughts of killing yourself now? When's the last time you thought about suicide? Or when's the last time you thought about death? I mean, it's not like a question, but I'm saying it's in the same tone, like you'd have a conversation. If you're acting fearful yourself, oh my God, we're going to ask these questions, because what if you say they are? Well, that's why we want to be trained on suicide prevention, so you know what to do. And I would even say to Teresa earlier, I'd really like to, I said do follow workshops with this group. And I think something like that training, and even training on ethics or training on clinical interview skills, whatever, could be really helpful for next step. Okay, so let me just see. The other thing, other than suicide, I was going to talk about things like, one thing I wanted to say was about disclosure. So there was a comment about disclosing, Teresa was talking about a patient was going through a similar situation that the therapist is. The question is, when is it okay to self-disclose? Like some therapists might say, well, it's okay for me to tell the patient that I also went through that, so it kind of normalizes it. But ask yourself this question, is the disclosure of whatever it is about you therapeutic? If it's not therapeutic, leave it out. It's just that simple. We don't have to get complicated. And if you say you want to talk about yourself because you think it'll help the patient because you can explain what you did, that doesn't mean it'll come across as a therapeutic benefit. It may come across, well, yeah, look at you, you're a therapist, and you're sitting there telling me what you did, but the person's in therapy to get help for them, not necessarily hear our story. Just think, is what I'm about to say therapeutic for this patient? And if you cannot come up with yes, then you be quiet. Default to quiet. It's really okay to do that. Even if the patient asks you, do you understand what I'm talking? Have you ever had this happen to you? You don't need to answer the question. Go on with your clinical assessment and say, I know this is difficult to talk about, and I really appreciate you staying with me so I can understand more of what you're going through. So not that you're refusing the question, but you can reframe the way the conversation goes. Or you can just say the truth, you know? Because some people think if you haven't been through it, then you can't help them. That happens so much in substance use if you haven't experienced that. Where the patient will say, well, have you ever had a substance use problem? Have you ever been addicted? Well, then you can't help me because you have no idea what it's like. And, you know, it's that old analogy of like, wait a minute, how many illnesses do I have to have? And can I even survive those to be helpful to the range of issues that come before me from many patients over the years. If I had to have every one of those disorders, including substance use disorder, to be able to be helpful, I mean, it's just not logical. So we say, oh, I'm trained in this, and I'm here, and if you find value in us working together, great. If you don't, let me know. It's okay. We can see if we can work together if it's a good fit. If you find our therapy together is helpful, great. If not, I would really like you to speak up and let me know, because then I can refer you perhaps to someone else that may be a better fit. Or you can decide. It's your choice. So I mean, it's things like that, staying with an unconditional positive regard rather than feeling offended. Recently I had a patient that was kind of attacking me a little bit. You know, Dr. Watson, I've been in these sessions now 4 times and I'm still feeling this way and that way. I mean, what's the plan? And I didn't laugh. But she is so re-traumatized. So re-traumatized. I won't even go into detail, but it's layer on layer on layer on layer of stuff she's going through. And when she comes into session, it's almost like, get it out, you know? And that's okay with me. Get it out, tell me what's happening, because every week it's been something else. And really hard for her to handle. And she's almost at the point where she's now under medical care as well as psychological care as well as seeing a psychiatrist. So she's got a good team around her, which is good. But she was kind of, what would the word be? So I became the bad object because I wasn't fixing the problem fast enough. But she was making choices about some things she was doing that was actually resulting in re-traumatizing. So she wasn't really following treatment recommendations. Like, let's slow down with that decision. What do you think about slowing down with that decision and just kind of stabilizing a little bit? Because she's thinking about moving or leaving the country or this or that. You know, it's all like, maybe. It's like, I just need to choose one. I said, well, do you need to make a decision about that today? Would it be okay if you just remind yourself you don't have to make a decision today? You could identify your options. If you'd like, we can talk about those and maybe narrow it down if you want my help with that process. But she's still making decisions to move again. And so, I mean, she did calm down in the session, you know. And I told her, I said, you know what, it's okay for you to vent, I'm here, I'm with you. You want to vent? I said, I'm okay with it. If you think that you're disappointed with what's going on in therapy, okay, I want to hear it. Tell me more. So when you disarm like that, which is, by the way, one of the what really works in anger intervention therapy, which is what I call it. That's my thing I'd really like to spend time talking about in the workshop or whatever. The technique, so to speak, or the process, is to agree with something that the person is saying. Find that angry person like this patient. She wasn't angry like out of the chair ready to throw anything at me. It was just letting me know, where are we going? What's going to happen? How come I'm still traumatized? How come? You know, and I had choices. I could say, well, if you stop making these stupid decisions, maybe you can calm down. And if I use the word relax, which I didn't say, of course, that's going to push her right out the door. And probably me with her. For me to say that, I'd probably be feeling pretty inadequate and not representing the profession, for sure. So I'll hold back, even though I noticed I had an emotional reaction for maybe 10 seconds, you know, just kind of like, She knows she's been re-traumatized. But anyway, I wanted to do the unconditional positive regard and let her feel safe to say whatever she wants, and I'm still going to be here. And that's, I think, the way to handle that. And it may not be easy to do that if you have an angry patient, But that skill is to learn how to detach yourself from the patient, but still have empathy, positive regard, continued clinical assessment, treatment, all that, right? So you see, it's complex. And so if you want to be in this field and do well, which you can, it just requires your preparation and your openness to learn. And I really advocate for advanced education. You can learn a lot right where you are, but if you want to actually, become certified, credentialed at a practice level where you can do all kinds of things, trainings, teach, your own private practice, work with a group to go work on ending suicide without assessments, work on a workshop to create a recommendation to the medical community and psychological community to use assessment tools and do workshops. And I would love to do that if anybody's interested. One of my passions before I came back to Kenya in 2010, and then I went back for a couple years and came back again in 2021, so I'm here now. I'm less interested in spending time in the States, although I go back once a year to see family and stuff. But I'm really feeling like my work now, for as long as I have left, whatever that is training. Because I think training peers, psychologists, entry-level counselors and psychologists. I think the more we work with entry-level, that's where really it'll bubble up into making a difference in the country. Because we have more entry-level, quote-unquote, meaning either a bachelor's or no bachelor's, a diploma, or whatever. With that group is where we could really start doing effective training and make a difference. I mean, that's my opinion. I would like to now just open it to see if you have any questions or anything I can answer. Yes. There's some CBT stuff I was going to talk about, like core emotions, cognitive distortions, self-defeating beliefs, anger interventions, scales, and a whole bunch of stuff that I actually do teach. In fact, there's, let me see, like 4 people right here who could teach it too, most of it. But I felt like, let me just not overload you. We've been sitting for a while, and I've kind of said my piece, so. But I would love to work with you guys within this setting to get more detailed into skills training, so that you have a greater sense, perhaps, of even to start the therapy session. And one of my classes is psychotherapy skills lab. That's what it's called. And what I'm doing in that class is we do role practice. The whole 3 hours. So I might be the patient, and the student is actually practicing clinical assessment. And we practice maybe first session, which is going over treatment consent, and exceptions to confidentiality, and blah, blah, blah. And then go right into clinical assessment. So we're practicing a lot of that, and that's what I think would be helpful here. What do you think? Okay. All right, anybody have any questions or comments, or, yes?
Thank you so much for that. I'm really learning a lot. I am a young person. My question is, what is the place of technology as we are speaking about training about mental health? How can we be able to incorporate technology in these things that you've been able to teach us?
How do we use technology?
Yeah.
What do you have in mind? More specifically? Go ahead. Okay. Do you have something in mind that you're thinking about in terms of using technology?
I know with the young generation it's quite much more easier, but I was asking, normally from where you stand, I know you've had some good time to live here, and so it is, do you think there's a way, especially now with people of your time, I know most of them don't appreciate technology, is there a way to be able to work with them, with technology, so that we're able to push this knowledge more and more to further generations?
Well, the technology that we're using right now is more like Zoom, using Zoom virtual sessions. I do virtual sessions with some patients in California. California. I have some patients that live in Kenya but not in Nairobi, so can't be face to face. That's the technology that's happening now, and there are new ethics about that have been developed in terms of virtual psychotherapy. And sometimes it can work and sometimes it can't. But the only other thing that comes to mind in technology is really about training. There is so much out there in podcasts. There's some really good trainers in the States. David Burns comes to mind. He has a few good books out there, but David Burns is awesome. He has a lot of free stuff he does. He's actually a psychiatrist, but he's written books on
The gift of therapy.
what?
The gift of therapy.
The Gift of Therapy, thank you. The Gift of Therapy, that's Young.
Yes.
That's Young, Irv Young. But that's an excellent book as well, The Gift of Therapy. And that one I think you can get on a soft copy. There's a lot out there on soft copy. But the one on David Burns is Feeling Good and Feeling Great. Those two different books. And that's a lot about cognitive behavioral change, how we can change our intrusive thoughts, negative thoughts, how we can reframe our thinking. And you know, when we're able to do that, we can come from irritation to calm. We can come from sad back to calm because we're learning to shift our thinking. That's the whole CBT thing, a lot of detail, but not difficult to learn, especially with role practice and so on. But there's a lot of good stuff out there, not just those two professionals. Gottman is a third one. Gottman.com, Gottman. John Gottman and his wife are up in Seattle, Washington. For years they have, and still do have, a lab. They're doing a lot of research, particularly on couples. But they also do other research in other ways as well. But the couples research surfaced them to become like the experts on what predicts a healthy relationship and what predicts a relationship to fail. And that research was done over years because it started at a certain point with a group of couples where they would videotape and watch how they spoke with each other. And because they had pre-interviewed, they kind of knew the hot button to bring the topic in. Okay, so now start talking about the dog. The dog's behavior, because that's a big argument, for example. And so they videotaped that and they listened to the language that the couple used with each other. And then later, I don't remember the longitudinal conclusion, if it was 10 years later or whatever, but they followed up, many years later, to see who was still together and who wasn't. And they went back to the tapes, the videotapes, this is a lot of work, right? And a lot of research assistants, to see if there weren't any patterns, any clues there were. And it came up with like over a 90% prediction rate. Can you imagine? In mental health research, we don't see 90%. 90% is high. Anyway, so what they found, it boiled down to 4 destructive types of communication that either both or at least one of them was using. And that became the source of what predicted a relationship to end. Imagine how valuable that is for us to know. So guess what I'm doing with couples? I'm talking about Gottman. I refer them to the website. I bring out the handout. And I'm teaching them the 4 destructive types of communication, and I'm asking them to identify which one they use the most. I'm not saying to you, I'm not asking you yes or no. Do you use any of these? Oh, no. Which ones do you? Which one? And if the wife can't say, or the spouse, or the partner, can't identify, if the patient can't identify, I'll ask the partner. And I'll ask both of them this way. So, do you identify with using any of these? Or he or she or the partner says, no, maybe sometimes I'll be defensive, but no, not the others. And I'll ask the partner, well, how do you see that? And this, all 4, 100%. But it's just a way of kind of having a conversation. So here's the 4. Stonewalling. Stonewalling is nonverbal. There's no eye contact, completely ignoring the person, and the message is, you don't exist. So one of the partners might be in a sitting room watching TV or reading a book, whatever they're doing, gardening, who knows. And the spouse or partner comes to them and says, hey, didn't we decide we were going to do X, Y, Z this evening? Are you wanting, is it time to get ready and get going? And the person doesn't even turn their head, doesn't look at them. If they're, whatever they're doing, they just keep doing it. And there's absolutely no eye contact and no verbal at all. Not even rolling your eyes or anything. The message is, you don't exist. Can you imagine? You see how negative that is? It's like, go away. You're bothering me like a fly. You know, go away. The second one is contemptuousness. Contemptuous is also nonverbal, no words, but there is body language. So the person is kind of glancing at their partner, and then they'll do this like, you know, like, or roll their eyes, or just like, but there's no words. It's just these defiant, you disgust me, is what is being said through contemptuousness. You disgust me. Anyway. Third one is accusations. Well, you're the reason the bank account overdrew. You were supposed to go put that deposit in. That's your fault. Why don't you get more responsible? What's wrong with you? Are you a child? No. Accusation, accusation. And the partner comes back with defensiveness, which is the fourth one. It wasn't my fault. You're the one that said you wanted to take over the finances because you wanted to be equal in the relationship. Can you imagine? You hear this all the time. So, there's a lot being said right in that statement, right? A lot. But, yeah, I want us to be able to make money and financial decisions together and plan together. That's what we agreed on. But you said you wanted to take the checks at the end of the whatever and do the deposits. So, what happened? So then, and you failed, so here's an accusation, you failed at what the agreement was. You see, now what am I supposed to do with that? And she'll, or the other partner will just go on her own for a few minutes, you know, just dig it in, you know? And so then the partner will come back with even more defensiveness or accusations. That wasn't the agreement. You were supposed to go to the bank, not me. I'm the one out there working. You have more time off than I do. You're supposed to go. So there's more accusation. You see how, what's the message in that? Do you hear any love? Is there any love? Is there any love in stonewalling or contemptuous accusations or defensiveness? There's no love. So now these people are coming into therapy and they're looking at you. It's like, we need help. I would start with bringing in Gottman's work. You know, I want to bring in the experts into this session of what's already been researched, and they don't even believe me. I can say, here's the research, here's the book. You can order it. You can maybe even look at Gottman.com on internet, which is wide open for anybody. There's stuff in there for parents, couples, therapists. So anyway, this is a huge finding from the Gottman. They call it a love lab in Seattle. Still called that. And John and Julie Gottman are still together and still doing research there. They do some trainings with psychologists or counselors, and I have attended a couple of their trainings in the past. But they also do a lot of online training. So feel free to look it up. Okay, shall I conclude? Yes. Getting yes, okay. Well, I'm open, as I've said, to this table and all of you, that I'm happy to join in the progress and support your goals. And I think it's important that you speak up and say what you want, if you choose to your trainers. You know, would you like to do psychotherapy role practice? Would you like to learn suicide assessments? You know, what do you want to learn? And you could show up and do a half day or whatever's planned and start working on it. Thank you. Thank you. Did I leave any gems? Gems. Oh. Sorry. What I'm asking is, you know, at the beginning I kind of said, I hope to leave you with some gems. You know what that means? Like, some powerful information.
Yes.
So I want feedback. Did I succeed?
Yes.
Okay.
Thank you so much. I think that was personally, Professor, thank you because you reminded me Gottman, and this comes in very handy. Yes, for my job. Thank you very much. Who can give Prof feedback? What did you get? Yes. 3 people. 3. Only 3 people. We start at the back. The last 2 tables. Any of you? Anything? Yes, you. Beatrice.
She said something very important. During a session, you don't need to tell your client or your patient that you have gone through that. You can keep it to yourself. So that I got it very clear. Thank you.
Very good.
Wow.
We want to make the session about them, not about it. Yeah, good, thank you.
Okay, next. I like corners. Corner table. Christine, your table. Anything you got, you can even discuss and agree who's going to speak on your behalf.
Wow, what a wonderful talk we've had. I've had a lot. We've had a lot about everything. Yeah, I'm very grateful for what I've got to hear from you. It's really good. I would also like to pass it down to you to tell us more about what you also have.
That's smart. Thank you. Thank you, Christine. It passed on to you. Tell us.
Okay, I'd like to thank the professor on behalf of the students who don't have a chance to talk. I'd say what you've taught us and what you talked about how can really help us and benefit us in the upcoming challenges we face. Maybe we have clients that will really help us. Yeah, thank you.
Thank you very much. Thank you. Team Allsmiles, I'm with you. Tell us, what have you learned?
Okay, I've just learned about your being mental, especially as a therapist. I just like to listen, give them space, time, just allow them to talk. Then come in when you're supposed to come in. And then next one on, I think I'm jealous of those professors, students. Yeah.
She's jealous of your students. You can join them. That's the beauty.
You see Dr. Ambrose over there? That's where he was, step at a time. That's what you think I could do this? Come on. We were all somewhere once, and we just put a commitment in front of us and found empowerment to continue.
There's one more? Yes.
So I think mine is to say thank you and appreciate you. I'm learning from an outsider's perspective, especially your talk on ending stigma, how well the experts here can be able to create awareness around it while still maintaining the professionalism.
Yeah.
And also your emphasis on industrial organizational psychology, which I think is lacking. We need to put more emphasis on that. So I think from an outsider's perspective, we really learned a lot. Appreciate it.
Thank you so much.
Thank you, Lynn.